So the last three talks today are going to be from our first cohort. These are the folks that started 3 years ago. And so our first presenter is going to be Jessica Ma.
Hi, everyone. I'm really excited today to talk about my K12 project, as well as kind of where I'm going from here. I first wanted to just thank my mentors, as well as the K12 program, from the PWLEs to the directors, in addition to Laura Watner, for all of their support throughout these last 2 years. So a little bit about the agenda. We'll talk a little bit about what I am, which is a palliative care physician, the HEAL K12, and my future projects. So what I usually like to say to patients, because most of the patients, when they get consulted with us, is usually, what is palliative care and why are you here to see me? And what I usually say is that I've been consulted for, say, their chronic condition, specifically, usually in this case would be advanced kidney disease. And then in addition to that, there's two areas of focus that we really will focus on in this consultation. The first of which is symptom management, which includes pain, nausea, vomiting, fatigue, poor appetite. Along with that is making sure that the care that we deliver is in line with what's important to the patient. So this is really the essence of palliative care, and in that clinical appointment, we'll address the physical, the psychosocial, and spiritual aspect. And then we'll talk a little bit about my HEAL K12. So specifically, my K12 focuses on older adults with advanced kidney disease. And the reason for this is that the majority of these patients have poor long-term prognosis and quality of life. The median lifespan for those with a CKD stage 4 and above is actually roughly around 3 years, regardless of whether or not they receive dialysis. Half of these patients have chronic pain, and about a quarter of these patients then are also prescribed opioid medications. However, many of the treatments that we offer these patients, especially for their pharmacologic management, which actually includes non-steroidal anti-inflammatories, muscle relaxants, gabapentin, are actually associated with increased side effects for these patients. And the benefits of managing their pain is really unclear, especially when we're weighing additional side effects to getting pain relief. Yet, when we look at these national guidelines, there's actually specific wording in there that it just says that we exclude palliative care patients without a definition of what palliative care patients even means. And because of all of this is that clinicians, the way that they practice varies widely. So you just talk to one person, they practice in one way, another person will practice in a different way. So my research question for my K12 was, how do older adults with advanced kidney disease and their clinicians weigh and communicate decisions around pain management? And there were two parts to this. The first one was a qualitative study with patients and clinicians, and the second, a discrete choice experiment. And within the qualitative study, we started to ask clinicians and patients, how do they approach decision-making on their pain management? We included patients that were older than at least 65 years old, had a pain numerical rating scale of at least 4, at least 2 times over the past 2 years, or they were prescribed opioid medications, an estimated glomerular filtration rate of less than or equal to 30, which is a stage 4, 5, or end-stage renal disease for these patients, a pain intensity, enjoyment of life, and general activity scale of greater than or equal to 5, and at least pain greater than or at least 3 months. So meaning that the patients that we were interviewing had moderate to severe chronic pain. We also interviewed physicians or advanced practice providers, so including nurse practitioners and physician assistants in the following specialties of primary care, geriatrics, palliative care, and nephrology. So we interviewed a total of 24 patients and 24 clinicians. The mean age for these patients were 73 years old, majority female, half were white, and half were on dialysis. The other portion included, for clinicians, were clinicians who were in practice for at least 9 years. Majority were female, white, and majority physicians. And we identified 3 themes, specifically on navigating treatment complexity and uncertainty, identifying and addressing fragmentation of care across specialties and the care team, and also divergent preferences among these patients and the clinicians. So the first one that we really notice, especially among the complexity and uncertainty, is that clinicians often weigh multiple factors to develop their treatment plans. But many of this, even though they have a very formulaic approach, is mostly in their head. They don't necessarily explain it to the patients, all the different things that they're actually thinking about to make sure that the treatment plan that they're offering is the best one, or the ones that are probably the best options for the patient. So they think about safe medication types and doses, the potential side effects, especially for this patient population, the risk of addiction, insurance coverage, because sometimes we want a certain medication, but the insurance requires all of these prior auths or reasons that they failed one before they can get to the medication that they think is the best. Cognitive impairment, which may mean the forgetfulness, can they even handle one medication per day versus 3 times a day? Transportation, if you're talking about non-pharmacologic treatments. So all of these things are in the clinician's head as you're thinking about it, but rarely did a patient actually even talk about these things other than, I need to avoid certain medications in kidney disease, but less so about all of the different things that are needing to be balanced when we're talking about these patients. In addition to this, other clinicians described how hard it was to describe this process to patients, and that they're very worried about the patients actually feeling overwhelmed by this process. When we're talking about fragmentation of care, there was actually broken communication between different clinicians that could even lead to divergent recommendations. And one patient described this as not having someone to overlook everything. And then they're there, after going to all of these different doctors, trying to figure out and filter out what really makes sense to them, and really just finding that it's just very frustrating in the whole process. And then when we're thinking about divergent preferences, there were conflicts stem from multiple different things, one of which was medications. It wasn't just opioids. It was also muscle relaxants, NSAIDs such as ibuprofen and naproxen, non-pharmacologic treatments, even acupuncture. There were divergent preferences for the patients as well as clinicians. When we're talking about the medications, it could be dose reductions, stopping a medication, or even starting a new medication, all were potential conflicts. And then along with all of this, one patient also discussed how the feeling of the lack of treatment options also just made them feel kind of the fact that they just had a lot of conflict with that with their clinicians too. And the one thing that we also noticed in here is the fact that the benefits and risk perspectives were very different among the clinicians. And so when the clinicians started noticing that, hey, your kidney disease is getting worse, we need to start readjusting your medications, but the patient is feeling, hey, things are working for me right now. Why are you trying to change something that is working? And as these things change in the course of their comorbidities, as a patient's age, we need to start readjusting things, but then how do you explain this when those views are different? And within the first aim, we started also looking at how potential strategies to overcome some of these communication challenges. And some of the communication strategies that we identified included open communication, specialty care coordination, validating patients and their experience, a value-centered approach, in addition to patient advocacy. So around open and frank communication was really for both clinicians and patients to find a way to discuss the challenges and also tailor it to kind of the patient's health literacy and understanding. So one patient actually described that they really wanted the clinician to communicate to them with honesty, that they recognized the brutal experience it could be, the life-altering experience, but recognizing that the clinician's honesty to say like, hey, we don't really have a lot of options, that we might not be able to find the perfect combination, is just very much more supportive for them to really then figure out how do we then approach the best management that we can for me. In terms of specialty care coordination, is really developing how do we have different direct paths of communication between the specialists, whether including the patient or outside of the patient, to make sure that the best care is provided. So one clinician described how a patient had this intractable shoulder pain, but she was a bit older, so they actually reached out to the orthopedic surgeon and then collectively decided together that a surgery was the most appropriate option for that patient because they were very active, and having the surgery would then make sure that they would hopefully maintain this activity that they had before. Another one was just making sure that the patients were feeling heard. And a consequence of that for this patient was that she felt that she wasn't being heard at all, and that because she didn't feel heard, she ended up actually just not even discussing it with the doctor anymore. She just left and just went to find her care for her pain somewhere else. In terms of value-centered communication, a clinician really kind of led their visits with patients by trying to figure out and asking the patient what was the most important to them and what was bringing them meaning in life, so that they would then be able to cater the type of recommendations that they would have for their pain in that way. And lastly, around patient advocacy was mainly actually, both patients and clinicians described this in different ways, but a lot of it was how would a patient be able to advocate for themselves, whether in an appointment and outside an appointment. And specifically, this clinician described it as, you need to know to ask every single doctor, how is this new medication going to affect my kidneys? And so there were several findings that we had from here that led to future directions from my AIM-1. So first of all, one of which was evaluating the different perspectives by specialty. A lot of the interviews that I conducted with the clinicians, we actually saw kind of the differences that each specialty would also bring to the picture and what their majority they would like to focus on compared to another specialty, and how then could we combine all of these different skills to really then best provide care for the patient. Examining patients' preferences, especially in non-pharmacologic treatment options, and then also developing interventions to really support safe and effective pain management. So I'll focus on the second one because this will lead a little bit into my AIM-2. So from AIM-1, we actually went to a discrete choice experiment survey, which is looking at how patient preferences on non-pharmacologic treatment management. And from our AIM-1, we actually saw and talked a lot with both clinicians and patients how social economic factors may contribute to what treatment preferences these patients would actually choose. From this, the frequency of the visits, out-of-pocket costs, and even travel time. And a little bit more about explaining, going back a little bit about for those who don't know what a discrete choice experiment is, it actually combines different combinations of treatments and characteristics, and then offers to see relative patient preferences and also weighs potential trade-offs for these treatments. So this is an example of what we presented to patients. Because of the fact that they were older adults, we actually only gave them 2 different options. You can actually sometimes have a lot more just to make it a little bit more specific in terms of what they could choose. We had a treatment type, expected pain level after the treatment, function level, the frequency of the treatments, the out-of-pocket costs, and travel time. And then this was an example question that we actually presented to them. So they would have 2 different treatments that they would choose from and the expected pain levels, and from these, and out of these 2 options, they would then have to choose which one would they prefer the most. And so far, since starting AIM-2, we have enrolled over 90 participants, which is amazing. 50 of these surveys have been completed, and we are hoping to get 150 by the end of this year. Fingers crossed. And there are some bumps in the road since I've started this K12 project. I took a 3-month maternity leave right at the start of year 2. So it's been a lot of learning how to prepare and anticipate these breaks and during research. And it was actually my 3rd kid, so it's been a busy season. And it was also the reason I wasn't here last year. He is now officially starting to figure out how to walk, so we have a walker. I had actually a lot of difficulty hiring a research coordinator. I actually probably emailed 20 or 30 different people to try to figure out how can I find the support I need to run this experiment, which was even more important because of that 3-month maternity leave. Cross-institutional research, I have been making connections where I'll have a graduate student at another university working on a secondary analysis for my AIM-1, but that's also been kind of a lot of institutional processes that I've been just learning along the way. And also with these experiences, I think I've been able to help mentor and kind of other early career faculty who've been trying to navigate these institutional rules and I's that need to be dotted, T's that need to be crossed, as well as some of trainees too. And lastly, I competed unsuccessfully for a VA CDA and another CDA program, and I've transitioned over to writing NIHR grants. And with this learning opportunity, that the K12 is really one of the bridge to my research independence. Along the way with the K12 program, there's been so many things I can say about the program itself. It's been one of which has been working with persons persons with lived experience, one of whom, Lynn Matalana, had been so helpful in helping me talk through recruitment processes, my interview guide in AIM-1, and also my survey development for AIM-2, the PWLE curriculum, as well as the panel who gave me so much good feedback for my R01 submission, and mentorship also from the K12 directors, from Dave Williams with my AIM-2 discrete choice experiment, networking, and brainstorming, and Dan Claw with helping me brainstorm my R01 ideas. So a little bit more about my future projects. So the main one being developing interventions to support safe and effective pain management. And I've been thinking about kind of two different directions with it, one of which has been testing non-pharmacologic interventions. The other is also evaluating methods to support safer pain management in high-risk populations. I'll touch on one and expand a little bit on the second one, because the second one is the one that I've been canoodling a little bit more. So the first one is a small R01 that I submitted this past June, which is a feasibility pilot on meaning-centered pain coping skills therapy, which has been tested in advanced cancer populations, and we're hoping to bring it into the advanced kidney disease population. And the second one is the one that I've been thinking about a little bit more, which is a multidimensional pain management for older adults with advanced chronic diseases. So it's bridging from just advanced kidney disease to advanced chronic disease, mainly because the issues that we see in advanced kidney disease, I also see in a lot of my cirrhotic patients, patients with cirrhosis, patients with COPD, patients with heart failure. So a lot of the issues that we still contend with are actually fairly along those same lines. And the first thing that I like to think about is really in those patient-clinician interactions, when I start asking patients about how has your pain been, what has your pain level been, and then we get this score, and a lot of these scores are input into the electronic health record, but it's just a score. It doesn't tell a lot about the quality of life and the impact that they have on patients, the impact on sleep, the impact on function, and all of which I think play even more of an important role in how we manage pain than just a score itself. And so one of these things that I have been thinking about is when we're thinking about measuring beyond just a score, what are other measures, data, and information that we can incorporate on not only the patient and clinician side, but then combine it all together to really feedback and provide feedback for both the patients and clinicians while we're managing their pain. So specifically thinking about when we're starting a new opioids, because I'm probably one of the few people that still start new opioids on patients nowadays. And their impact over time on quality of life, function, sleep, but as well as, especially in this population, side effects, such as falls, hospitalizations, and others. And then this question for this specific R01 would be, how can we support that safe and effective pain management for these high-risk populations? So one thought was, as we're looking at the opioids, as we're looking at these other things, that we can actually also add in activity data and patient-reported outcome measures and combine all of these together to then kind of feedback to both patients and clinicians to hopefully support better pain management decisions. And so the aims of this would include characterizing longitudinal physiologic and patient-reported measures over the 12 weeks, identifying phenotypes based on machine learning clustering, and then pilot testing the integration of this data into the electronic health record, so then we can hopefully go forward to a trial setting at that point. So in summary, thinking about the fact of my specialty as a palliative care physician, my HEAL K12, which really introduced the idea of the treatment complexity and uncertainty, the fragmentation of care, and divergent preferences, especially among older adults with advanced kidney disease. And the fact that we can now identify some communication strategies as well as patient preferences for non-pharmacologic treatments, and my future path in terms of my future projects to developing and testing pain treatments for older adults with advanced chronic disease. So I will stop here and see if there's any questions. Oh, yes.
I appreciate the inclusion of the spirituality piece, because a lot of times patients will say that's really important to them, but it's not included in non-cancer or non-palliative care chronic pain research. So I was just curious, like, what some of the findings were in that area in general, if you analyzed that data yet, and how that might inform your future work.
So the spirituality we didn't include a lot in this part for the M1 and M2, but it definitely is going to be a part of the small RO1 that I had recently submitted. So I'm hoping that that'll bring a lot more picture, because I agree. I also, since I'm at Duke, I'm also within the Bible Belt in North Carolina. So and being also at the VA, I think gives you a combination of a lot of patients who really value spirituality, especially in this sense. So one of the things I think really, along with all of it, is I believe completely true that spirituality should be front and center, along with a lot of the other types of measures as we're looking at better supporting these patients too.
So first of all, really excellent presentation. You're a fantastic presenter. I'm so engaged the whole time. One of the questions I ask is, you're really focused on older adults and kind of gerontology, but I'm wondering, even thinking at the VA, there's a lot of folks who are younger and middle age who experience this kind of really severe chronic pain. And so little pain research is done with and around younger and middle-aged folks who experience pain. Do you see any of your, and I know you're still emerging findings, or a third of the way done so far, can you see how any of this would apply through the lifespan, and or do you have any thoughts about how these findings could be used by providers who see people at kind of different stages in their life?
I think that's so important, as well as someone, because we're in palliative care, I usually operate on very little data, so we do things so off-label all of the time. And I will say that I think that's probably the next frontier of all of this, is like, once we find that there is significance in the work for these interventions in certain populations, can we then bridge it into the other populations to make sure that it also works in them? Because the one thing is, if we practice off-label, is that it's not going to be supported by insurance. And that's one of the things that I'm hoping, is that as one group, the next group, and we find that these things are hopefully working, that we'll be able to keep rolling it out so that more and more patients have access. Really good point.
Just a thought about your sort of immediate future directions for, like, getting into the RO1 game and getting your applications in there. So one thing to just consider is, like, the CATS mechanism right now is currently expired.
It is, yes.
Right? So maybe in fiscal year 26 it's reissued. Keep an eye on that. But perhaps a lot of times people want to focus on that because it has a sort of no preliminary data requirement. So I would say two things. One, take a good firm look at what you do have in hand for preliminary data, and if it's insufficient, it makes me wonder if, like, perhaps an R34 or something meant for intervention development might be a good mechanism. But if not, I also find that folks often overestimate the amount of data that they would need to actually pursue that R01. And I'm just thinking, like, with what you got going through this K12 and your discrete survey sort of data, you get to like 100 some odd people. Preliminary data is a weird balance of not enough, and then it looks like you're just making stuff up, but too much, and why do you need to do this study anyways? Yes. So all I'm going to say is, like, don't sell yourself short on just the good old-fashioned non-small R01, and perhaps let me grip. But also don't sleep on the R34.
Okay.
Could be a mechanism.
That sounds like a really good idea. Thank you. Tom?
Yeah, great presentation. Really impressed. In the future, do you see work toward empowering the patient even more by getting their stories and incorporate, having an interface with the medical health, the electronic health records?
Yeah, that would be amazing. There have been some in the palliative care literature, at least, on getting patient stories within the medical chart. Some institutions have implemented it, and that would be, like, really, really neat to do as well. So both at the VA side and non-VA, I've seen some of the smaller studies around it, but the question is then implementing on a greater scale, especially, I think, on less of the palliative care patients, but I think even the chronic pain patients too. Agreed. Mark?
I think I missed this. I really love the qualitative portion and the section where you were sharing how participants felt like they were heard. I was wondering what were some reasons that were provided from participants. They attribute that to their
So that is a fascinating question because we tried to ask them and no one would really give us a firm response. And one of the things that has been also in my mind is we actually probably need to get into the room and actually start really recording these conversations, because some participants would be like, yeah, my doctor hears me so well. And we'll be like, how so? Silence. And they might give very general tips, but it's very interesting because I think the patients who are able to communicate well just have learned those skills over time and don't recognize how innate those skills are to them. And recognizing how those innate skills can be passed on to those who struggle with communication, especially with the clinicians, would be so useful, but those might not be really pulling out because those are within the clinician-patient encounter specifically, and they might not notice how they've actually pulled those things out to really advocate for themselves too. But great question. Awesome. Okay.
Okay, our next presenter is Lakeya McGill.
Okay, everyone needs to take a moment and just like stand up or move around or wiggle. I don't know about you, but I need that a little bit before I get started. Okay, so my name is Lakeya McGill, and I will be presenting on my K12 experience, including progress, challenges, and lessons learned. I will be starting off with a brief introduction. I will talk about previous research, particularly related to sickle cell disease and stigma. I'll talk about my K12 project aims, progress, and challenges, my K23 proposal and other next steps, my career and professional development overall, and then final thoughts and conclusions. So I typically start with the positionality statement, sharing a little bit more about me and who I am, because who I am, my worldview, my background, influences everything that I do, including my clinical work, my research, the questions that I ask, and how I view the things that I find. And so I'm trained as a clinical and community psychologist. As a community psychologist, I think about the environment, the community, structural factors, systemic factors, and how they impact health outcomes. I'm also a Black woman with an invisible disability. I was born and raised in a small town of about 7,000 people in Tennessee. And I do not live with sickle cell disease, and my close family members also do not live with sickle cell disease. However, several of them live with chronic pain. And this is an image of my family. In terms of my education and training, I completed my bachelor's degree at Rhodes College in Memphis, Tennessee, then a post-bac program at VCU. I earned my PhD in clinical and community psychology at UMBC Boston in Maryland. And then I moved to Seattle, and I completed my one-year residency in behavioral medicine at the University of Washington. I moved back to Maryland and completed 4 years of postdoc, 2 years as a clinical fellow in rehabilitation psychology, so working with people with stroke, TBI, spinal cord injury, a wide range of conditions, as well as many with chronic pain conditions. And then I completed a 232 research postdoc where I specialize in pain, health equity, and sickle cell disease. And then in October 2023, I started my faculty position at the University of Pittsburgh in the School of Medicine. So overall, my mission is to advance high-quality pain care for adults with sickle cell disease. As a psychologist, I've had the privilege of really hearing detailed stories from patients, families, and clinicians. And oftentimes, those stories center around pain and stigma, both understudied issues for this population. And so based on that, my career goals are really long-term to develop, test, implement effective psychosocial and multi-level interventions for pain. So the patient level, the clinician, the healthcare system, as well as then thinking about the policies. My more immediate or intermediate K23 goal would be to develop and test an individual level stigma reduction intervention for this patient population. And then my K12 project really examines the impact of intersectional stigma on pain outcomes in adults with sickle cell disease. And so a little about previous research. So sickle cell disease is a genetic blood disorder that affects about 8 million people worldwide and 100,000 people in the United States. The condition is characterized by many complications such as anemia, stroke, organ failure, but the hallmark symptom is both acute and chronic pain. The acute pain is vasoocclusion or pain crises, in which the sickled red blood cells lead to blockage of blood going throughout the body. And it's the most common cause of emergency department visits. They also experience chronic pain, with over 50 to 60% actually experiencing chronic pain, which is mostly managed at home. But overall, this acute and chronic pain negatively impacts people's health outcomes and quality of life overall. So after conducting this research for the past 13 years, there are a few observations that I've noticed. So one, sickle cell disease is an understudied and underfunded population. We have historically focused on biological factors, which is understandable. There's been some research on psychological factors, but there is far less that's really looking at the social and cultural impact of living with sickle cell disease and the role of these factors. And then even more so, interventions are not addressing the social cultural aspects. And so this is central to the work that I do. So when people experience severe pain crises, they often seek care in the emergency department. And unfortunately, when they go to receive care, they're faced with negative attitudes, they're faced with long wait times, often longer than other populations, especially in a crisis like they're experiencing. They're also often viewed as drug seeking and malingering. They're not believed. And of course, these experiences of stigma lead to worse health outcomes. And so what do I mean by stigma? Stigma is labeling, stereotyping, discrediting, or excluding an individual or a group. It can be based on multiple dimensions. So the source could be the healthcare providers, could be family, friends, the general public, in multiple settings. Could be in healthcare, could be at school, could be at work, as well as based on multiple characteristics. So it could be based on your race, your gender, your age, whether or not you have pain or if you're prescribed opioids. And there are 3 types. So one is experienced stigma or discrimination. Then a person can anticipate or expect that they're going to experience these negative experiences. And then internalized stigma is when a person actually adopts these society's negative labeling and views of themselves or their health condition. And overall, this can lead to things such as increased depressive symptoms and increased pain severity interference. So sickle cell disease can occur in people from all backgrounds. However, in the United States, it's most prevalent among people of African American descent. And so it's important to consider the racial aspects of the condition. However, that is not all of it. It's more complex than that, and we must consider intersectionality. And what I mean by intersectionality is that we have an individual across their life course, from infancy to older age. They have multiple intersecting identities, be it their gender, whether or not they have disability, their sexuality, and then that's influenced by all these various systems. It can be ageism, racism, ableism, and all these things influence a person's lived experience. Intersectional stigma is the application of intersectionality that focuses explicitly on stigma and discrimination. And this is very relevant to sickle cell disease, as individuals with the condition can experience stigma based on their race, their disease status, pain, and whether or not they're prescribed opioids. And so what I want to do, based on this previous research and lack of much of it, is that as a part of my K12, I conducted interviews with adults with sickle cell disease to, 1, explore their experiences of intersectional stigma, 2, to examine how it impacts pain, and then I also wanted to identify how adults with sickle cell disease actually manage and cope with these experiences. And so in the literature, we're constantly saying that stigma is an issue. It's brought up almost every paper that I've read. We talk about how much is an issue, but I think there's maybe one paper that I've seen that really got into how do people cope and manage with this stigma and discrimination, and it was in Brazil. So I haven't really seen many that focus on that in the United States. And we also don't have many interventions to actually address the stigma, which, as I have said, it really needs to be multi-level, but there was really only one that was developed 10 years ago that was focused on stigma in adults with sickle cell disease as an intervention. But as a part of this interview guide, I'm asking people about their experiences of stigma, both within and outside of healthcare, how it impacts their life, how do they manage it, as well as thinking about their support system, because the stigma and living with a chronic health condition really extends beyond the individual and is also impacts their family and the people within their particular network. Some of the challenges that I faced as a part of this project so far has been, one, that I transitioned from postdoc to faculty and I transitioned to a new institution. And so that was a big change. And I'll say things that helped me was really leaning on my mentorship team. I asked a lot of questions. I also really connected with peers that were around, near peers, people around the same career stage as me, where we're learning together. So that was really important. I also developed connections with mentors who were both within the K12, but also outside of the K12. I hired a research coordinator, which was critical. And if I could, I would also work to have a postdoc working with me. Also had some challenges in writing an interview guide that focused on intersectionality. I was really trying to figure out how do I ask questions where I can get at those structural and system level factors, which I wasn't really sure how to do that. Thankfully, I was able to get mentorship and recommendations from a qualitative expert, an expert in intersectionality, and my various mentors, people with lived experience who were able to give recommendations and feedback. And so that was really helpful. Also was a huge learning curve in terms of learning about qualitative methods and analyses. So I have taken like qualitative courses, but I think that actually implementing these things and going through the entire process can be easier said than done. And qualitative work is quite a bit, especially when we're getting at these complex topics. And so again, I really have been leaning on my mentorship team and getting advice about what are the best books and trying to figure out what my approach is and my lens through this work, and really balancing when do I want to take a course versus other ways of learning. And then the other big challenge is really trying to figure out how to appropriately engage with people with lived experience. And I think for me, it's been really just showing up as my authentic self, remaining open to opportunities and learning. I've asked Chris, and she's provided amazing feedback and recommendations, learning from the person with lived experience panel through the K12, and just knowing that it's going to evolve over time and I'm going to get better. Despite these challenges, I was able to complete data collection. I have data from 27 adults with sickle cell disease. We have started to review the content analysis, which has taken quite some time because it is 100 pages of content. It was a lot. People shared quite a bit. They were very enthusiastic. And so we're working through that to develop the themes. I will be sharing some preliminary themes. And then we're going to be reporting and publishing on this. So in terms of the sample, the mean age was 36 years old. Majority of the participants identified as female. About half had higher education. About 44% were unemployed. Majority were not even married. A high percentage, over half or below, had an income below $35,000, and then many were on disability, received disability insurance. There were many different genotypes, with the most common being HBSS, which is sickle cell anemia, which is the most common type of sickle cell genotype. Many were receiving disease-modifying medications, such as hydroxyurea, and then 74% were taking opioids, with fewer on chronic opioid therapy. The preliminary themes were that, one, most experienced substantial acute and chronic pain that interfered with their function, and it worsened with age. Most report experiencing intersectional stigma, especially in the emergency departments, where they were saying that they were being actually disbelieved about having sickle cell disease. They were disbelieved about the severity of their pain. They mentioned that it was based on them having sickle cell disease, their race, and many times things would also come up around gender. So there's a lot of intersectionality there. I want to take a closer look at the systems and structures as I continue to look at the data. And then they used various strategies for coping with it. They talked about family and friend support, religious and spiritual practices, mindfulness and acceptance exercises, advocacy. They also talked about holistic practices, marijuana, and there's complexity with that because they often are even screened for substance use when they go into the emergency department. So many methods. Also took a closer look at internalized stigma because I'm particularly interested in it. Most reported actually experiencing some internalized stigma. They felt alone or like a burden at times. Some had negative views of themselves. And this evolved over time with them having more negative views during childhood, but they learned how to better cope over time and in adulthood. And some example stories was that one participant shared, "When I think of myself, I just think of sickle cell, but that is not my identifier. I am not that disease. I even asked my boyfriend one time, why would you want to date someone who is sick? And this person said, because I don't see that, I see you. But the participant said, I try to force myself to understand. Sometimes I do, sometimes I don't, because I just sit in the hospital very often just alone. Nobody's there, even the nurses, they're like, oh, nobody comes to visit you. My sister used to, but has quit jobs just to be there at the hospital, taking me there to the emergency room, but now she has a child. So she's not able to do that because that baby cannot come to the hospital. And so this story really demonstrates a lot how this person's experiences of living with sickle cell and the potential stigma really impacted how they view themselves. They didn't understand why someone else would love them and want to be with them. They talked about that loneliness of being in the hospital and how this impacts the entire family. Another story, the person said, when I was younger, I definitely went through times, questioning, am I wrong or am I lazy? Am I not doing enough? Am I causing myself harm? I definitely went through all of that until I got to know myself better, understand that it wasn't me. I can't help it if people don't understand the disease. I can't help it if people don't know. I can't. I try my best to explain it to them and teach it to them, but I can't help it if they don't want to learn it. So this person was grappling with talking about the challenges and how they question themselves and how they approach things maybe when they were younger, but how that really started to evolve and how they started to acknowledge that they try to educate people and they'll do the best they can, but they can't control how others treat them necessarily. And then the third example, this person really talked about how they didn't really have internalized stigma and there really wasn't much more around in resiliency. And they said that living with sickle cell, it prepared me for life a little bit, more than just being tougher, going through the pain, learning how to endure pain. I would definitely say my pain tolerance is higher than a lot of people. I definitely say it strengthened me just for, the road ahead, just life in general. So they were able to manage living with pain, but also learned a lot about life through living with sickle cell. And so based off previous research, including this work, I've been thinking about my next steps. And my next steps are, I want to do interviews with clinicians. I have already started interviews with care partners and families. And then I also would do a survey, both at baseline and 6-month follow-up, to look at the mechanisms that are linking this stigma to pain outcomes. So as I said, I've already started interviews with caregivers. The goal is 24 participants, but we already had 37 screen eligible and completed the pre-screen survey, which I'll talk a little bit about. I have already completed personally myself 10 interviews, and they've been very informative. Even though I've been doing sickle cell research for 13 years, I have learned so much through those interviews. I always hear people talk about stigma and that people living with sickle cell are viewed as drug seekers, but I get more specific examples. So they said things like they will do a screen of drugs for the patients when they come in for treatment, even though that's not the typical protocol. They said that they talked about the location of the hospital and how it might be ran down in the particular place where the sickle cell centers are. So they really were providing great examples that I want to think more about. Almost everyone talked about stress and stress as a trigger and the mental health impact of living with sickle cell disease and the stigma and the challenges that they faced, as well as the impact on the family. So building on all this work, I've really been working on the sickle cell disease stigma and pain framework, where I'm thinking about these experienced stigma, thinking about intersectionally, leads to potential internalized stigma, then depressive symptoms, and then worse pain severity interference. I'm thinking about how we have protective and resiliency factors that can buffer against these outcomes, such as adaptive coping and social support. And I also want to note that I've heard the importance of thinking about anticipated stigma, so that is something else that'll be a part of it moving forward. But overall, this all is a part of my K23 that was submitted earlier this year, and the goal of it is to develop and test the feasibility of a stigma reduction intervention. And so some just preliminary ideas for this intervention would be to something like beat stigma, build an empowerment advocacy. This is not a final name, as when I hopefully eventually get funded for this, I want to work collaboratively with the community-based organizations, people with lived experience, including patients, families, clinicians, and community-based organizations to develop this intervention. But the idea would be something like education about stigma and its relation to pain, address how stigma affects people's thoughts, emotions, and behaviors, and then helping people to strengthen strategies to cope with the stigma and pain. I was thinking that it could potentially be a group intervention in a community-based setting. However, I love the point that you brought up, so kind of thinking about what would be the best format. Would it be group and individual, and people being able to decide? So that's something I'll keep talking to the community-based organizations and key partners about. And then my training goals for this K23 would be building on the K12 training and something like expanding expertise in community-engaged research, gaining in-depth training in psychosocial intervention development, acquiring knowledge and skills to lead RCTs, and then overall just enhancing my skills to function successfully as an independent investigator. Whenever I developed the K23 proposal, I did receive amazing feedback from the K12 person with lived experience panel, who were people living with pain. And then I also received feedback from the Pitt CTSI Community Engagement Studio, which was people with sickle cell disease. They really showed up. They really valued being able to provide their perspective. I think I've shared this with other people before. I mean, I literally had someone who was diagnosed with sickle cell in their late 20s or 30s. Someone who was actually in the hospital was a mom and her son. He was in the hospital for a cure, and they showed up for that community engagement studio. There was someone else who was in Nigeria. It was midnight at the time that she showed up for this community engagement studio. And then there was someone whose daughter had recently died from sickle cell. I mean, I was so touched by how much people wanted to show up to share their perspective and to strengthen the research. Some challenges related to all of this is that there was some challenges with managing the study recruitment. So like I said, I actually over-recruited for this recent, with the interviews with caregivers. Again, it just spoke to how much people wanted to provide their perspective, because oftentimes, at least in sickle cell, when we talk about caregivers, we're talking about caregivers for children, but I specifically was saying I want to hear from caregivers and family and support system for people once they become adults, because they continue to need support. It continues to be a family and community impact. Also, it's been interesting navigating recent NIH changes, being someone whose research is focused on stigma and discrimination, as you all can imagine. So that's really been leaning on my mentors and really trying to reflect on what are my values, how am I going to approach all this, what will make me years later feel proud of how I approach things. And then also I've had to adapt to mentorship changes. So both of my co-primary mentors just left Pitt. So I have to figure out my mentorship. They've been very supportive, though, in terms of being willing to continue to have meetings with me. And so I just want to shift to talk about overall career and professional development that has been made possible through this K12 project. So Thankfully, I've been able to have 11 publications since October 2023, so in a little bit less than 2 years, plus 1 book chapter, 15 presentations across international, national, and local settings, and then 9 posters. I was selected for an alumni award through my postbac program at BCU. I've attended 7 conferences in the last year and 9 months, including the USASP, Canadian Pain Society, Purpose, Intersectionality, Summer Intensive, ISP, and SCDAA, which is a conference that is really more patient and community focused and facing rather than like more of our academic conferences, which was also an amazing experience. And then I've had many national leadership opportunities, including being able to mentor postdocs and graduate students, being on the Hill subcommittee that was focused on the intersection of pain and substance use. There was a panel on sickle cell disease and Social Security disability evaluations, which is a passion of mine, thinking about disability. And then also there's a new sickle cell SIG through USASP, which shout out to USASP too. And then some others is that I'm an advisory committee member for the National Center for Dignity in Healthcare and Community Living in People with Disabilities, Diversity Committee co-chair, Rehab Psych, and then through USASP, multiple committees and groups I'm a part of. In terms of more locally, I've been trying to find ways to get connected at the University of Pittsburgh as being someone new. Been able to just have amazing trainings, K12, which was amazing in terms of me writing my K23. And then I've been able to be a part of like, CHAMP was the center that I was a part of that's focused on pain. I was on the executive committee for their T32 and their planning committee, and then just other amazing opportunities, including mentoring and advising undergraduate students. Through the K12, my specific development, we all have been a part of this. I want to shout out certain ones. So I really have enjoyed the Neuroscience 525, where I was able to learn more around the like biological aspects of pain as someone that's more focused on the psychosocial. So that has been informative into my learning and growth. I also really appreciate Mishar. I think my favorite part was the 3-minute presentation that really challenged me to think about how I communicate about my science and my passion. I also really appreciate the K12 check-ins and the monthly meetings. And then again, just so much gratitude for the K12 PWL panel. And so my final thoughts are that overall, my goal is to advance high quality pain care, particularly for adults living with sickle cell disease. Taking into account intersectional stigma and discrimination and really multi-level care. I'm incredibly grateful for the K12. And I will say my largest lesson that I've been focusing on is really progress over perfection, especially during the current times. Special thanks to my K12 and home mentors, as well as the K12 directors, my research coordinator, Emily, all my various peers and colleagues, and then my funding.
Oh, yes.
Certainly incredibly well done. You're speaking my language, talking about micro, meso, macro, positionality statements, intersectionality, and both in the current time and generally, these are not necessarily things NIH is, and especially pain research, is used to. I'm wondering if you've experienced any tension or areas of growth and expansion and how you talk about your work and how you frame your work in a space where that often hasn't happened before, and any of the lessons you've learned from that?
Great question. So as I said, I think I've had to do quite a bit of just like reflecting on my values, what I will and will not compromise on, which feels challenging as an early career faculty versus someone who's more senior. I just have had to reflect on that. The other thing has been, sorry, I lost my train of thought. Can you repeat the question again?
Yeah, I'm just wondering, the way you frame your work is very different than a lot of, not just pain research, but NIH research and what people are looking for
Yes, okay, yes. So yes, it's been reflecting on my values, thinking about what I will and will not compromise considering all this, but also trying to remain flexible. I think there have been ways in which I've thought about how to protect myself. So depending on the presentation, depending on if I'm being recorded, I may or may not show more images of my family. I may or may not go into more detail about my identity and who I am. I have continued to really talk about still systems and structures because I just feel like that's critical. Yeah, I don't know. So I don't really know what's the right way to do it. But what I'm also learning is that my mentors and most of us don't know what we should be doing at this time. And so that's why I've been just like leaning into how will I feel about my decisions 2 and 5 years later. I don't.
Outstanding, Lakeya, thank you. I'm really curious when you start interviewing, or you've already started interviewing healthcare professionals. I think there's another layer of stigma
Okay.
that those who are advocating for sickle cell patients providing opioids, because that's unfortunately what most with chronic and severe pain need at some point in their disease trajectory. There's stigma that those individuals are facing.
Okay.
And further compounding the patient's stigma, the shortages of opioids and the insurance companies, the way they treat opioids right now. Patients are going through withdrawal because of delays. I know you know all of this, we've talked about it, but I'll be really fascinated to see how much of that comes out of your interviews.
Okay. So for everyone, Judy is one of my amazing K12 mentors, as well as Rob. Where's Rob? Okay. So I would love for us to talk more about that whenever I get to the point of developing the interview guide for the clinicians. I have been hearing a lot around the complexity in terms of even people getting on buprenorphine, and so like how much they're explaining that to people's stigma around that, how the clinicians feel about it. So I would love to talk more in detail about that because I think there's a lot going on.
First of all, I have to compliment you on your flyers. Those are the first flyers I've seen that I can actually read. So I know you had a patient file, so well done. Could you address the issue of past trauma? You talked about stigma when people were young. Does that include the trauma that would be involved in that?
And do you mean trauma in general, or are you talking about trauma related to like in the hospital, in medical trauma, in medical? If this my questions were not specifically about trauma, I think there's a lack of research in trauma and sickle cell disease. I think it is a huge need for more around that. So, for example, when my mentor and colleagues were writing a book chapter, we were wanting to talk more about it, and there's very little on trauma and like PTSD and early childhood experiences in the population. In fact, you all who do maybe with pediatric sickle cell might know more than I do, but in adults, it's limited. Good question. There's more need for that.
And I would expand on that. So 2 that come to mind in my own caseload, many people with sickle cell disease have lost loved ones.
That's
Siblings,
true.
Cousins, so that's huge trauma.
Mm-hmm.
Many of my young female patients have gotten pregnant and have been advised to have an abortion. Thankfully, Illinois is a state where but that's still a traumatic event, despite all the regulatory stuff.
So true. That was so much has come out of the caregiver interview. So I didn't do the interviews with the warriors, which is what people living with sickle cell often refer to themselves as. I did not do them with the warriors, but I've been listening to all the transcripts. I've been reading all the materials. But with the caregivers, I've been doing them. And it's been a lot of insight into just like fertility and family planning. And someone was just talking about how hydroxyurea them being concerned about that leading to fertility in the men. So such a need for all of that. And I imagine that's traumatizing.
Yeah, well, it was always great to see the work that you're doing. And I have one question and I have one comment. Can you speak a little bit to what your sampling strategy is for finding the clinicians that you're going to interview? Because I imagine that you might get a lot of
Yeah, I think it needs to be during, like, before that transition period. That's what I like. So I'm like focused on adults, but as I was seeing the results, I'm like, this needs to be when people are like adolescents before that very difficult transition period. For those who don't focus on sickle cell, when people, they go from pediatric to adult care, it is a particularly challenging time because they experience more stigma and more disjointed care as adults than the way care is set up in pediatrics. And so them just needing more support about that transition and just trying to go from even like, for example, school, where it might be a more clear process around an IEP or a 504, once you're trying to think about accommodations in college or work, it just is not as straightforward. And then your other question, I love that you asked that because I forgot to mention, is that a lot of my recruitment is through community-based organizations versus through the clinic, which is I think where most people actually recruit from. I think that has led to my recruitment being quicker because it's like me developing in relationships with community-based organizations. More people are actually getting like information about the opportunity to participate in the studies. However, I have to be very mindful to make sure we don't get like bots and just like really careful about who is able to then be enrolled in the study. And for the clinicians, I haven't figured out where I'm going to recruit from yet, but I think that's a good question in terms of being mindful of like, where are we recruiting? Are we recruiting from these big healthcare academic medical centers or like general like hospitals? And I mean, people talked about the difference in those types of things, even in those interviews. Any other?
All right, and our final presentation this afternoon is Bridget Mueller.
Thank you so much. Thank you so much. I'm Bridget Mueller. I'm acutely aware that I am standing in between you and your ability to leave this very chilly room. So I will do my best to keep us all on track. So you'll be hearing from me again tomorrow. So Sarah suggested that I focus this talk a little bit more on tips and tricks for our incoming K12 class, as well as talking a little bit more about the progression of my project. So this one will be a little bit different than others. So I'll start with a little bit about me, and then I'll talk about my K12 topic, which is stress response systems. I'll show just 1 or 2 data slides. We'll talk about next steps, how the project evolved, and some tips scattered throughout. So about me, I am a headache specialist and the research director at the David S. and Ruth L. Gottesman Center for Headache Treatment and Translational Research. I also co-direct the Autonomic Laboratory at Mount Sinai with my amazing mentor, Jessica Robinson-Papp, who's here. I am a mom to Gavin and Cora. This is Antoinette. I share your love of travel. This is in Hawaii. We were watching the sunrise very early in the morning. And I spent the first part of my career as a bench neuroscientist. So this is one of my early studies that I'm proud of that showed prenatal stress led to downregulation of receptors in the hippocampus, which is a really important part of our brain for learning and memory, right? And this downregulation of receptors actually leads to upregulation of stress, right? So you think about that, right? A developing brain exposed to stress says, okay, I've got to get ready. I'm gonna have a stressful life, right? I wanna upregulate those systems that are going to keep me alive, right? Stress keeps us alive, right? Acutely, it's really important. The problem is when we're sitting at our desk, right? It's not good, right? We don't want to be in constant fight or flight. And so this really drove my desire to go into pain medicine. So I went to medical school, and then I had residency, and then I did a fellowship in headache and pain management. And my very patient husband at one point said, when are you gonna get a job? How old will you actually be? So, during a migraine, stress response systems like the hypothalamic pituitary adrenal axis and the sympathetic nervous system become activated, right? This leads to our system being flooded with catecholamines, free fatty acids, cortisol, glucose, right? And having to live with migraine is so stressful, right? You don't know, forget about the attacks, right? You go through life not knowing when one's gonna happen, right? So you live in a state of hypervigilance, of wondering, what's this trigger? Can I eat this? Should I not eat this? And I can tell, right, when a patient has had a migraine or is in a state of chronic migraine by the way they look, right? The most important part of my exam as a physician is watching my patients walk from the waiting room. I have this wonderful medical assistant, and she's always trying to help me, and she's saying, no, let me get the patient, I'll bring them to your room. I say, no, this is the most important part, because the patients don't realize I'm watching, right? And so I can tell if their pupils are really dilated, if they're shuffling, if they're avoiding the lights, right? If they're wearing sunglasses in the waiting room, that tells me about the level of their disability and how they're living their life. And so episodic migraine, although it's a terrible disorder, right, there is a return to baseline in between attacks, right? It's a intense, incapacitating event that lasts between 4 and 72 hours. But then after that, it's over, right? And the patient returns back and they feel relatively normal in between these attacks. I don't see these patients, rarely. I see patients with chronic migraine. So patients with chronic migraine, this has been somewhat arbitrarily decided as 15 or more headache days per month, right, with 8 meeting criteria for migraine. These patients don't return to their neurological baseline in between attacks, right? The migraine persists, and I'll talk a little bit more about this tomorrow, but their sensitivity to light, to sound, to smells, it persists. It's how they live their life all of the time. Particularly what can be very debilitating and is almost rarely talked about unless you ask is orthostatic intolerance. Patients have a terrible time just remaining upright. They feel dizzy and sick, and that is what is keeping them from driving their kids to school, from going to work themselves. The pain is terrible, but they can kind of function with it. It's the dizziness and the orthostatic intolerance that really keeps them from living life. And so when thinking about this very broad constellation of symptoms that basically impacts the entire nervous system, right? One thing comes to mind, which is the autonomic nervous system. And there's 2 arms, right? If you think back to high school bio, right? There's the fight or flight sympathetic nervous system, and then there's the rest and digest, parasympathetic. And patients with migraine, during a migraine, have activation of their sympathetic nervous system, right? It's fight or flight, go, go, go. When we stand up, we rely on this intricate mechanism, this reflex called the baroreflex, right? It keeps our brain perfused. When we stand up, right, 1/2 liter of blood goes from our big intrathoracic vessels down into our feet, right? There's a slight drop in blood pressure and the brain says, hey, I need some more blood up here, right? So the lower extremity vessels constrict, pump blood back up, and this happens within seconds and you never know that it's occurring, right? That's the autonomic nervous system. It's autonomic. You don't realize it's happening, right? The other part of the autonomic nervous system, which gets the short thrift, but it's the sensory afferent system, right? In order, and this was brought up a little bit, I think, with your question about interoception earlier, right? This is the system that's telling the brain what's actually going on, right? How fast is your heart beating? How fast is your gut moving? And this is gives us our awareness of what's going on inside of our body. And so there's increasing sort of interest about, in patients with chronic migraine and other chronic pain conditions, is there a general heightened interoceptive ability? And so one of the reasons I became really interested in the baroreflex is that patients with migraine have a couple of reasons to have a dysfunctional baroreflex that could potentially explain why so many of my patients tell me they're dizzy, right? We know that stress decreases the sensitivity of the baroreflex. And this is an adaptive mechanism, right? We want blood pressure and heart rate to both go up, right? When we're stressed, to escape the lion, right? We need blood pressure, heart rate, up, up, up. Inflammation decreases the sensitivity of the baroreflex as well. And endothelial dysfunction also decreases it. These are, mechanisms that we know are part of migraine. And so my first aim of my K12 was examining this question: do impaired autonomic reflexes explain why so many patients with migraine have orthostatic intolerance? And this was one part, and we looked at other symptoms as well, but this is what I'll focus on today. And so we enroll patients with migraine, both episodic and chronic, and we test them in our autonomic laboratory, where it takes about 90 minutes to 2 hours, continuous blood pressure and heart rate monitoring, which it's also, there's a tilt table test, some deep breathing exercises, and then we also have some measurements of the sympathetic reflexes that don't involve the baroreflex as well. And all of this data that I'm going to show you is collected by my amazing study coordinator who does everything. She is a regulatory expert. She collects the data. She schedules the patients. She analyzes the autonomic function tests. And I would be totally lost without her. So this is my first tip. Your first hire is likely your most important one, right? Although I have an amazing mentorship team, your boots on the ground, you are a team of two, right? You are calling patients, you are doing the IRBs, you are doing everything together, right? And so if you have a good person, it makes all the difference. So I looked for a while before I found Maya. I interviewed a bunch of people, and then she came down and we had an in-person interview, and really take some time, I think, to find a good person would be one piece of advice. Okay, I'm gonna get emotional at the thought of Maya leaving me next year, so we're gonna move on. So the one piece of data that I did wanna show you is data from a cold pressor test. So the cold pressor test is a test of neurovascular sympathetic function. A patient puts their hand in a bucket of ice water for up to 3 minutes. I'm not using this as sort of a QST or a marker of pain, although we do measure that. And the normal response is an increase in blood pressure, which you can see on the graph on the bottom, that green line that's the normal sympathetic response. And this is a reflex, right? Your endothelial cells that line the smooth muscle. There's release of norepinephrine, again, which constricts the blood vessels, and then that pumps the blood back up, and your blood pressure goes up. So we looked at patients with episodic migraine and chronic migraine, and we found that no patients with chronic migraine had a normal response to this test. So you can see the episodic migraineurs, their baseline in blue is they're averaging, 115 millimeters of mercury for their baseline blood pressure, and then their maximum goes up the expected amount of at least 15. Now, in some other types of disorders, right, you can have an overshoot, right, and you can be up 30 or above, but this is a normal response. Anywhere between 15 and 25 is expected. And you can see there's very little change in the chronic migraineurs. And this persisted even when we corrected in multivariate logistic regression for the amount of time that patients spent in the ice water, the amount of pain that they rated. So this, we felt, was a really interesting finding that might explain why patients with migraine have orthostatic intolerance. Because if there's failure, again, when we think about this peripheral neurovascular unit, right, pumping blood back up, there's compensatory mechanisms, right? Your brain cells will die without enough blood, right? So your backup stress systems come into play. Fight or flight, your sympathetic adrenal medullary system pumps out catecholamines, we pump out glucose, pump out cortisol, and so now you have tachycardia. And so this is in fact what we did see, which is that patients with low responses in the cold pressor test had a huge heart rate response on the tilt table test. So where are we going from here? So we are going to continue our phenotyping of stress response networks. We have some immunohumoral profiling to complete. We also have samples to look at cortisol measurements and the HPA axis, and we also are now working with Dr. Hart to institute some quantitative sensory testing in this next phase of work, and this I'm working to submit an R01 in October based on some of the data that I showed you. The next study that I'm looking at is a multimodal ultra-high field imaging to examine the central autonomic network, and I'll talk a little bit more about this later. We're also looking to see, can we predict a migraine using a wearable? And then finally, this is a center grant that I just started working on. Can we use hormone replacement therapy to improve migraines during perimenopause? I don't know about other clinicians in the audience, but I have found that pain during the perimenopausal period to be particularly refractory, and my interest in sort of sex differences and hormones has led me down this road to see if HRT could be one potential part of a treatment for patients with chronic migraine. So how did the K12 help me? So it really has changed my life. I don't know how else to say it, but the K12 has really, it hasn't just changed my career. Like the people that I've met, the networking has been really instrumental and changed the direction, certainly, that my research has gone. It also led to a $5 million donation, which is very, yeah. So I have a very grateful patient, and it's expensive to do research in New York City. And the NIH doesn't give you more if you have to pay a study coordinator twice as much because you live in New York City as you do somewhere else. And I had taken care of her husband. Anyway, a long story, which I can tell you over drinks, was she said, I will help you. You should take this opportunity, and I will supplement. So she gave me $1 million to sort of close the gap. And then she said, in addition, we're going to give you $4 million to start a research program, which is why we are now called the Gottesman Headache Center. So, yeah. So, the K12 has expanded my network. I now have friends. I realized I'm really a rheumatologist, I think. I just pretend to be a neurologist. I really disliked public speaking. I still don't like it. But I have gotten a lot of experience with public speaking through the K12, and I'm immensely grateful. Dan will help me and go through slides with me, which is kind of absurd given it's been a really wonderful experience. He's also helped me with study design. So how did my K12 research project evolve? So 2 years ago, I was here, and I had this grand plan of doing, as I mentioned, ultra high field 7 Tesla brain MRIs, because I wanted to be a bench scientist again. I wanted to go back and look at brains with exquisite detail and look at subregions. And Vitaly and Chris and Dan were let's rethink this plan, right? Let's think about feasibility and how are your patients with migraine going to feel in a 7 Tesla, and how have you thought this through, and do you have the actual connections and the collaborations to get this study up and running, because 3 years is not a long time, right? So I was very anxious 2 years ago at this meeting, because I like a plan. I like knowing what's going to happen, and the idea of totally changing my aims was terrifying, and I hated every minute of it until I had a new plan. And so we got rid of the MRI aim, and instead my committee wisely advised me, build a foundation. A research registry. It is not as exciting, right, as my fancy ideas to look at the hippocampal subregions, but it has proven to be an enormous well of really interesting data that I think will carry the center through, hopefully, a sort of new age of precision medicine in migraine. We also expanded our testing, right? I included the CPT. We're now doing some wearable studies. So it really helped me refocus and help me understand what was important at this very early stage in my career as a clinician researcher. So my tip number 2 is that at least one aim should be highly feasible, and you should be able to generate some data within the first 12 to 18 months. Okay, other tips. The Mishar Studio, very helpful. I have had an enormous number of years of education, right? Like a ridiculous number, but yet the things at the Mishar Studio, things that I covered, I never had been taught anywhere else. How to write a letter of recommendation, the importance of body language, saying no. No one had ever talked to me about those things before, and I had been to graduate school and postdoc and med school, and no one ever talked about that. I also learned how to be a leader, right? To use clinical research as a way to help reduce burnout in a busy tertiary headache center where everyone is refractory, right? My nurse, I cannot believe the interest. Like, my nurses love to talk to me about research. Even the other clinicians, they'll say, I have this patient, doesn't respond to anything. Like, could we enroll them in the research study, right? Because you're giving hope to someone who feels like they've run out of options. And you're also giving something for the clinician to say, right? Like, you've failed 37 meds, but like, here is this thing. You're gonna go and you're gonna learn more about your migraine. This is something that that Jessica and Lakeya did well, and I think earlier than I did, which is mixing up group and one-on-one mentoring meetings. I think I was doing all group meetings, and I think meeting one-on-one with people was actually really helpful. I remember meeting Chris was like super helpful in sort of tailoring my study and making it longitudinal instead of cross-sectional, and doing things like that. So mix up your meetings, I think, earlier. I think that's something I wish I had done differently. My last tip is have fun. Design studies that you would want to enroll in. I have been tested. Maya will tell you, soup to nuts. I've done the cold pressor test, and I think it's important to make sure that you design studies that your patients and people will want to enroll in and be informed and get something out of. And my daughter loves Taylor Swift, so I promised her that I would put something in about Taylor Swift. So my parting words is that the award is the work. I love my job. I'm so lucky to be able to take care of patients with pain and to do research, and I just want to keep doing it. And so I'm so grateful for the opportunity to be here. Thank you all. Questions? Yes.
The question we keep asking is, tell us about your patient, people with lived experience engagement in the design of this, in the dissemination, any of it.
Sure. So I talk to my patients about my research all the time. They are my number one. I had my patients try out stuff before we included the Empatica and the IRB. Before we sent the Empatica to the IRB, I had one or two of my patients who I've had for 5 years. I said, listen, can you wear this watch and tell me, does it feel funny on your wrist? Does it annoy you? Would you want to sleep with this? Could you sleep with this overnight? So I use my patients a lot in helping me design studies that they want to do. Chris was amazing and helped me in the beginning, and I think that those are the big two. Chris and my patients, of course. Yes.
What if you talked about this activation of this stress
Yeah.
Presumably that has blood-based biomarkers that you'd like to explore more. Do you think that there is a role for looking at some of these analyses that you're doing in terms of circulating cytokines or hormonal factors, and where would that play into your future?
Yeah. So we have bloods that we took when patients came for the autonomic function test, and we had proposed in the K12 that I would use the O-Link 96 biomarker for the immune panel to kind of get a sense of what patients' immune profile looked like. In addition, we have blood for hormones, so cortisol, testosterone, estrogen. We have this blood saved. I have some hesitations about it, quite honestly. And I think it's because if this were a perfectly designed study and I was working with mice and not humans, and I could have my subjects come at 7:30 in the morning before every autonomic function test, I would be more excited to run these tests. But there's such dramatic variations based on the circadian rhythm of these hormones just within a day, right? Forget about the cycle, right? Now, I mean, getting a patient in pain to come in for these studies is hard enough to say, oh, I would like you to tell me when your last period was, and then we're gonna figure out from 7 days, right? It's just not feasible. Like, that's just not the way. I would love to have those types of studies, but it's not gonna work. So I think, although we have this blood, I have to think really carefully about whether or not it makes sense to actually run it. And I think I'd be more excited to have patients do home testing. So they're now, in the past 2 years since I've designed this study, we have advanced our ability to test hormones at home, right? And that to me seems like a much better thing to do, to spend your money on, because then patients can do a salivary. They wake up, they chew a piece of cotton, they put it in the refrigerator. They do that for 30 days. Now we have cortisol measurements on every day of the month, and we can see what's the cortisol level the day before you have a migraine, right? And the same thing with, now we have these hormone panels that primarily were developed for patients who were trying to get pregnant, but they give us great measurements of estrogen, LH, and FSH. So I think I'd much rather go that route necessarily than the the one-time measurement. Yes. Yeah. Yeah, so it's really hard, and I don't have a good, I think you have to do what feels comfortable. I was lucky in that my donor basically asked me if I needed something. She was like, do you need anything? And I said, well, if you're asking, yes, I do. She was very excited, I think, about a migraine has been a field that has been dominated by men, clinician researchers. Most, if not all, of the big headache centers in this country are run by men. And so she was and is excited to support a female. And that is something that she is not ashamed to say. So she wants to support women physician scientists. In terms of getting up the courage, I think finding something you connect with, right? So for her, her husband, I treated with a sort of a treatment that's not typically used for migraine. It's like a daily naratriptan. And I said to her, my research is focused on understanding how we can match medicine to a person, right? And that's what I want to do. I want to prevent the years of struggle that your husband went through trying to find the right medicine. Like, I want to reduce that time. And that resonated with her. And she said, oh, that's a great idea. I want to support that. So speaking honestly about what you're passionate about, I think can inspire philanthropy. I was also very lucky. Yes, Tali.
I actually don't know your full story about the Bitcoin
Yeah.
And this is some of the companies operating putting your name on a building and something else and then whatever. And at the end of the day, you get like maybe 10% of what it was that the donor was interested
Right.
in. And I'm kind of curious whether that came into play in your path, but I think it'd be interesting for people in the room about that and how you were able to board that off. Or maybe your development office is way better than mine.
No, he's not. I mean, I don't. So this is coming up actually. So for the first donation, she is. I mean, she's very open about this. She doesn't care if I tell other people. But she gave $1 billion to Einstein to fund their medical students to make it free, right? So. The amount of money, although $5 million is a lot, for her it was not so much. And I think I've heard the term like starter gift, which I think was probably what that was for her. She was like, let's see what you do with this. And she was very experienced about how to write a tight proposal, right? So she was very explicit in her gift agreement that this money was to go to me, right? The $1 million was to go to me and the $4 million was to go to the endowment. And there were very specific instructions about how the endowment can be used. And that is important, right? To get the donor to, if that's what they want, right, then they have to write it down, because otherwise, you're right, the development will say, let's use this money for something else, right? And I think particularly, I don't know what Harvard's gift tax is, but Sinai's is pretty big. It's on the order of it's 25 plus an extra 7. So we're talking about a third of it, if it's not endowment, goes to the hospital. So they don't like endowments, right? They want the money in cash so that they get their 33%. So she is considering giving another gift that would be larger, and we are now kind of talking about how to structure that. And I am now having to sort of push back a little bit with development, so we'll see. But I think involving your donor about, like, I didn't need to tell her this. She specifically, I think, told me, weaponize this was her phrase. So I think she is on board with it being used to help the Headache Center. Anything else? Okay.
So I was supposed to do a wrap-up. I'm not going to do a wrap-up. There are a couple things I wanted to say. First of all, I mentor you all the time. A random piece of mentoring advice. Maya's not really leaving you. Maya will find, no, what happens when you work with someone like Maya is in 5 years after she goes to medical school, she'll come back and she's just going away for a while, just like when your kids go to college or whatever, she'll be back. She'll be back, okay? She feels as strongly about you in a good way as you do about her. So there's just like this cycle to people like Maya that you get involved in your research. It's super cool. The second thing I would say is you can just imagine how fun it is for people like me and Steve and Dave to help lead this program when you've seen like the entire day of just mentee after mentee that are just doing terrific work, and the future is like really bright for pain research. And the last thing I want to say, Laura, there have been a lot of people that have shown pictures of their babies. You have a beautiful 3-year-old baby. The gestation period was probably well longer than 9 months. For how much you had to work to get the K12 funded, some of the kind of innovative things that you put in the K12 and then that you put in the T90, R90 are just like, again, they were not regular training grants. We know how hard you worked to integrate some of these things into the grant. And I hope you're sitting and, as much as you possibly can, given the current circumstances, savoring this day. So that's it. I'm done.